I'm Monica Safford. I'm a professor of medicine in the Division of Preventive Medicine here at UAB. And I've been here for the last 12 years, and I've worked with both Dr. Willig and Dr. Curtis for most of that time. The part of the program that I'd like to describe to you today is called the Patient-Activated Learning System. And this is a system that we are developing based on the work that we're doing in the Alabama Black Belt, focusing on medication adherence and diabetes. And what we've done for the past year is talk to a lot of community members about what makes it difficult for them to take medications. Medication adherence is an enormous problem in medicine. It's estimated to cost $290 billion a year. Because about half of people who are recommended to take medications such as diabetes medications for chronic disease end up not taking it the way it's prescribed, and that ends up in cardiovascular events, stroke, heart attack, end-stage renal disease, and a whole host of bad outcomes that one would think patients would want to try to avoid. So it's quite puzzling to physicians why patients wouldn't want to take the medications that we recommend. So that was really what we set out to do. And what we're learning is that patients really do want a lot of information. But the painful thing for us to hear is that they may not want to get it from us or in the doctor's office. Many patients find the office visit a little terrifying because they're afraid what the doctor is going to tell them, bad news, more tests. So it's not exactly a teachable moment, which makes a lot of sense when you hear that, but I think for a lot of physicians, we want to try to provide education to our patients. The other piece that we're finding, which is widely known but really not very well addressed, is the number of misperceptions that people have about diseases and about medications and about the role of the medications. So what ends up happening, because people are not getting the information that they need, they're looking for it wherever they can find it, and they often get that information from friends, neighbors, family members, and worst of all, possibly ads on TV. So what we are doing is creating something that we're calling the Patient-Activated Learning System, or the PALS, which is designed to be an online web-based platform that is a single place where you can get all the information that you want about your health, about diseases, and about medications. Right now, if you go online, there are a plethora of websites that provide information for patients, so why do we need another one? One of the problems that people express is that there's a lot of information that's all over the place. So if you have a particular question, it's very hard to find the answer, and that's very frustrating. So we know that right now patient education materials are a little on the boring side. They're not very engaging to patients. Probably patients wouldn't want to read them more than once, and many of them probably don't read through the entire thing even that one time. So what we want to do, in addition to make this a one-stop shop that answers your questions, is also to use principles of something that's being called edutainment, so a combination of education and entertainment, so that the segments are very short with very clear objectives. They're designed to answer specific questions, and they're very engaging. So there are several online educational programs that are not health-related that we're using as models to sort of revolutionize the way patients receive education about health and their health conditions. So, how does the PALS relate to the physician and the physician encounter? So one of the things that we know in talking with both subspecialists as well as primary care physicians is that there are many things that become quite rote. So when you make a diagnosis, you have a patient that you've just discovered they have diabetes. You have to tell them some basic information, and it's very similar from patient to patient. I think it gets even more repetitive for subspecialists because they have a limited number of diseases that they're going to be diagnosing. And that gets pretty boring for the physician. So one of the things that we would like to do is bring PALS into the office. So if, for example, Dr. Curtis is a rheumatologist and he makes his 10,000th diagnosis of rheumatoid arthritis, he can sit the patient down in front of a computer and turn on that aspect of PALS that has a no more than 4-minute video about the basics of rheumatoid arthritis. And what we envision is at the end of that short segment, we will have what are the things that other people who've watched this also been interested in, and they can continue to click. They're activating the system by their questions and their interest rather than having something that's pre-canned that me as a health professional has decided that you as the patient should know. It's more, let's answer your questions first. And one of the other things that we want to do is offer, this is what doctors whose patients are looking at this material would want their patients to know. So patients both see what other people like themselves are looking at and are interested in, as well as what their doctor might recommend. So you can tootle along and fill out your electronic medical record forms or see another patient, and then you can come back. The patient now has had some very engaging interaction with the PALS system, has the basics so that you don't need to say that, and you can actually begin to have a conversation about this particular patient, their particular needs, and how to customize the treatment for them. So it really sort of gives a jump start and makes sure that the patient is starting off with a very solid foundation as opposed to the misinformation that people are getting now. So I think, one of the things that I'm increasingly convinced of is that patients are plenty activated and they're plenty engaged. But what they're engaged in is their health, not health care. And those are two different things. I think that the Patient-Centered Outcomes Research Institute is a great step in the right direction. But the next step after that is not to make it be the Patient-Centered Outcomes Research Institute, but the Person-Centered Outcomes Research Institute. People don't like to be patients. They don't like to have diseases. They don't like to be labeled as having a disease. They like to be people, and they like to be treated as people. So I think the more we can meet people where they are and really incorporate the things that are important to them as we design treatment plans, the better off everybody is going to be. One of the things that we're learning is that patients have a lot of questions that we currently don't have very good answers for. So, for example, they really want to know a lot more about the medication side effects. So the last time that you've gone to the pharmacy to pick up a prescription, I don't know if you pay much attention to the paperwork that they give you, but you walk out with a couple pieces of paper, and one of them usually has a very long and very scary list of potential side effects. There are no numbers. We have no idea when we're just reading that quote-unquote patient education handout. It's a laundry list, and in many cases, patients will look at that and decide maybe this is too dangerous a medication for me. So what we want to try to do is set the PALS up in such a way that in the first phase of it, it will be a question and answer database that can be used by patients of all ilks, every single health-related question, whether it's diet, safety of exercise, specific questions about diseases. We would like to create the system in such a way that we can actually engage the patients to be PALS and help answer questions that other people just like them have that we currently don't have answers to. So let me go back to the statin example to tell you a little bit more about what I mean. So statins are actually very safe drugs. They're among the best tolerated drugs that we have available. But they have very low side effects that are serious. So adverse events are very rare with statins. But much more common potentially are muscle pains as a side effect. You may have heard about this. It's surprisingly difficult to nail down how common is that. So if you talk to cardiologists, they will tell you, well, it's about 1 or 2% of patients who will have that. If you talk to primary care physicians, they estimate that it's closer to 20 to 25% of patients who have that. So if I'm thinking of starting a medication, the side effects are a very important consideration about whether or not I want to take this pill. So the difference between 1% and 25% is pretty big, and I think we should do a lot better than that. Not only should we be able to tell patients 1 out of 5 of you is going to get this symptom, but it is not severe enough to cause you to need to stop the medication and at least 3/4 of cases, half of cases. I don't know what the answer is to that. But I think that's the kind of information that I would want when I'm considering starting a medication, and most people feel the same way. So what we can do is create the system in such a way that it invites people. So if you're asking questions about statins, the system can ask you, are you considering starting a statin? And if you say yes, we can invite you to tell us how you feel every day for the first month that you're taking the statin. And that way, if enough people do that, we will begin to generate the answers to the questions that we currently don't have, but that the system will be designed in such a way to track what are the big questions that people have that we don't have good answers for. In addition to engaging patients in helping to find answers to questions that we currently don't have good answers to, we envision that the PALS can be integrated with other programs like RoomPro. So how might that work? If a patient has decided that they're going to be tracking their symptoms so that they can communicate better to their doctor how treatments worked or didn't work, or what the disease course is for them from the perspective of their symptoms and their functioning, with permission, we envision that the patient will allow the doctor to see what their traffic on PALS has been. So let's go with the rheumatoid arthritis example. Let's say a patient started a new medication because they were symptomatic, they were flaring. The medication, they start the medication, and a couple of weeks later they're having a little bit of symptoms. Maybe that's a flare, maybe not. Couple weeks go by, they're doing very well, then they're having another week or so where they may be having symptoms, and they start looking things up on PALS having to do with, this is a new symptom. Is this due to the medication, or is this due to rheumatoid arthritis? If you come to see the doctor and I can see, you've given me permission to see what your PALS traffic has been like, I can actually see what your concerns have been, mention that to you and say, I see that you've had some new symptoms that haven't really been familiar to you before. It looks like those symptoms may actually be from the medication. And we can start the conversation from there, as opposed to me having to get the history. You may or may not remember what you were concerned about at the time. So it actually facilitates the communication between the physician and the patient. And it can make much better, or it should be designed to make much better use of the time that you have available. So we typically see patients for 15 minutes when in primary care. Subspecialists may be a little bit longer, but it would be nice if we could spend much more of that time actually talking about the pros and cons and helping the patient to make decisions about what's right for them, what's working for them, what are the next steps, as opposed to having to go through everything that happened since the last visit, which the patient may or may not be able to remember. One of the advantages of trying to do this at UAB is that it's a full-service university. So we have collaborators in various schools. So I'm a physician, but I have collaborators in the School of Public Health, in the School of Health Professions, in the School of Education. And we're working with some folks in computer sciences to do this. So we have resources and intellectual capacity that might not be available elsewhere. And it's also very attractive to have the health system and to have such a large hospital and have so many patients that we could actually use as a little laboratory to see what works and what doesn't work before we launch something on a national scale. So from that perspective, it's what we would all love to do as health services researchers is try some things out and then have our patients here at UAB be the first to benefit.